My name is Noura Al-Qasimi, Vice President of Emirates Society of Ophthalmology, which is known as ESO, consultant ophthalmologist at Sheikh Khalifa Medical City in Abu Dhabi, specialized in medical retina and uveitis. On behalf of ESO and in collaboration with Emirates, we are welcoming you all to attending this webinar, which is all about uveitic macular edema. I am delighted to introduce our great speakers who are eminent and scientific in this field. First of all, Dr. Kwan Nguyen, who is Professor of Ophthalmology, Director of Uveitis and Ocular Inflammation Services at the Byers Eye Institute, Stanford, United States of America. He is actively involved in numerous clinical trials in the treatment of retinal and inflammatory diseases. He has published extensively in scientific literatures and in several books. He lectures internationally and is considered a key opinion leader in retina and uveitis. Our second speaker is Dr. Hassan Adhibi. He is a senior academic consultant at King Khalid Eye Specialist Hospital, Riyadh, Kingdom of Saudi Arabia. Chief of the Uveitis Division, member of Vitreoretinal Disease and Surgery Division. Dr. Adhibi's clinical research focuses on uveitis and diabetic retinopathy. He authored more than 50 scientific publications and has given more than 100 presentations in different national and international ophthalmology meetings. My dear colleague, Dr. Igor Kozak, who is consultant ophthalmologist and vitreoretinal surgeon, clinical lead and director of research and ethical committee at Moorfield Eye Hospital Center, Abu Dhabi, United Arab Emirates. Dear attendees, our webinar is live on Facebook and YouTube, and it will be uploaded shortly in ESO website. So all your questions will be answered at the end of the webinar, whether you can type in the Q&A or raise your hands. If you have a specific question to a specific speaker, kindly write his name so I can direct the question to him accordingly. This webinar has 2 hour CME. I will share with you later on the link at the end of the webinar, so you can ask or register for the certificate, and it will be directed to you, to your email directly. Now, for our attendees, dear attendees, we'd like to know about you. So I'm going to have like a quick general questions to engage ourselves with you and to as a warm-up. So Dr. Dina, can you share with us the first question? Where are you based in? Whether in UAE, in the Gulf, Egypt, UK, United States of America, or others? So 34 from United Arab Emirates. And the second question? Are you specialized in uveitis or retina like a VR surgeon, cornea or anterior segment, comprehensive or others? What I mean other, if we have dear colleagues in rheumatology or in family medicine, or a resident. So we are happy to have you in this evening's webinar. Others. So 18% we have uveitis specialist. Luckily we have 5% cornea. And good that we are having also a comprehensive ophthalmologist. The third question. How often do you diagnose uveitic macular edema in your clinical practice in general? Whether 10%, less than 50%, above, or none? %. Okay. And almost 20% less than 50. And the fourth question? It's nice to engage, to know that people around. So the most anatomic, I didn't get very detailed or deep questions. What do you think the most anatomic type of having, or the resource of the uveitic macular edema, whether anterior segment, stands for AU, intermediate uveitis, anterior uveitis, intermediate uveitis, posterior uveitis, panuveitis, scleritis, or you don't know? I hope the speakers, they don't answer that. Let's see. So all anterior uveitis and posterior uveitis. Okay. Excellent. Okay. And the last question. First line of the uveitic macular edema, what do you think? Observation, topical drops, anti-VEGF injections, systemic steroids, biologics. Systemic steroids. Okay, and 20% only observation. That's interesting to know. Okay, so the aim of our webinar is to review and highlight the latest updates in uveitic macular edema in different aspects. And with our first speaker is Dr. Hassan Adhibi. He is going to tackle the uveitic macular edema. So the mic is all yours, Dr. Hassan. We cannot hear you.
Yeah, it's a great pleasure for me to be with you in this great webinar that organized by the ESO as well the Mar Visions. I'm delighted to be with the distinguished speaker, Professor Kwan, and my close friends as well, Dr. Igor Kozak, as well you. I like the way that you started with these interactive questions as warming questions to know for our attendee what are their practice, how they will starting using to treat uveitic macular edema. So I'm going to start with my talk about uveitic macular edema, epidemiology, etiology, and pathophysiology. In fact, I don't have a financial interest to disclose in this. So what is uveitic macular edema? Uveitis remains an important cause of ocular morbidity, and uveitic macular edema is an accumulation of fluid in the most central part of the retina as a simple definition, and represent an important vision-threatening disorders occurring in the course of the various uveitis disease. And it is in fact associated more commonly with more posterior located uveitis like intermediate, posterior, and pan uveitis. If you look for the epidemiology, it's approximately 31 to 47% of uveitis patients develop uveitic macular edema in at least one eye during their uveitis course. And uveitic macular edema forms a major cause of visual impairment in 41% of the patient and could lead to blindness in 29% of patients if not treated on times. And loss of visual acuity in this patient may reversible and permanent loss of photoreceptor cells.
Dr. Hassan, are you sharing your screen? Because I cannot see your screen. Can you share it with us, please? Thank you.
It should be.
Yeah.
Shall I start from the beginning, or I can continue this? I think we don't.
Yeah, the most important topics. Yeah, and you can.
Okay, so this already been mentioned. So if you look for uveitic macroedema, can occur in all types of uveitis, and you already presented one questions regarding the prevalence of the and incidence of the uveitic macroedema among types of uveitis based on the anatomical classification. If you look at intermediate uveitis, almost 85% of the patient might develop uveitic macroedema, anterior uveitis 20 to 26%, and posterior uveitis around 20%. And panuveitis is 35, and should be suspected when the impaired visual acuity persists over several weeks after the acute onset of anterior uveitis. That related to HLA-B27 patient that presented with arthritis in 30% of the patients. If you look for the frequency of macular edema based on the anatomical presentation, you look for here that the most common cause that could be lead to the uveitic macular edema is intermediate uveitis, ranging between 25% to 60%. In another study done to compare, the frequency between two studies, if you look for the innate ETLs, a study showed that there is, progressive increase in the type of cystoid macular edema of uveitic macular edema, that more with the more located uveitis posterior. So if you look for that, intermediate uveitis almost 69, and the posterior uveitis is 71.5%, while panuveitis is 83. And you look on the other side, you find that in the graduate scheme study, it's a little bit, the numbers is less, but almost giving the same situations. We did one study in our institute in King Khalid Eye Specialist Hospital, and we find that the uveitic macular edema is around 5.5% in our patients. What are the causes of uveitic macular edema? We divide it in non-infectious and infectious and iatrogenic. For non-infectious causes, mostly related to Bahcet disease, sarcoidosis, multiple sclerosis, juvenile idiopathic arthritis, tibial interstitial nephritis, and uveitis syndromes. And ocular causes include HLA-B27 related uveitis, birdshot chororetinopathy, multifocal choroiditis, and panuveitis, sympathetic ophthalmia, facietic scleritis, and idiopathic anterior uveitis. And this is the question that you put it in your warming questions for our audience. Iatrogenic include that drug-induced, like prostaglandin, analogs, epinephrines, ribopatins, pseudophores, bisphosphonates, and sulmonidine, and the list is increased, as you see that, ended by tamoxifen and galactosamines. Infectious causes include syphilis, tuberculosis, viral, Lyme, cat-scratch disease, toxoplasmosis, toxoplasmosis, leprosy, diffuse unilateral subacute neuroretinitis, and onchocerciasis. If you look from the other side, the pathophysiology of the uveitic macular edema, the exact pathogenesis is not clear, but the cause of pathological fluid accumulation is attributed to disruption of retinal blood vessels in the macular area, that's representing the inner blood retinal barrier, and dysfunction of retinal pigment epithelium that representing the outer retinal blood barrier, as you see in this diagram and sketch. If you look in the other side of the sketch, that how to differentiate between vascular disease like diabetes and retinal vascular occlusion, and primary inflammatory disease like uveitis, we have an inflammatory mediators like interleukin-1 and tumor necrosis factor that lead to inflammatory protein depositions and permeability increase in this patient, vasodilation and leukocytosis, and of course ended by macular edema. So intraocular inflammation may lead to the disruption of both inner and outer blood retinal barrier by local inflammatory mediators, or by induced a systemic release of inflammatory mediators. And probably that combination of different factors lead to ocular inflammatory macular edema. Immune-mediated insult indeed initiate a chain of events at the cellular and molecular level, leading to upregulations of several inflammatory mediators like nuclear factor kappa light beat chains and cytokines like interferon gamma, interleukin 1 beta, interleukin 2, interleukin 6, and interleukin 8, interleukin 10, and tumor, of course, tumor necrosis factors alpha, and transforming growth factor beta 2. Arachidonic acid could be really involved in the pathophysiology of the euphytic macroedema, and indeed as well, in fact, vascular endothelial growth factor, it could be having a role in the development of macular edema. If you look for vascular endothelial growth factor, which is the interest substrate for a lot of medication nowadays, we have vascular endothelial growth factor that characterized by increasing vascular permeability, promoting edema and inflammation that lead to induction of fenestration in the vascular endothelium and lead to solutions of tight junction of the retinal pigment epithelium and attraction of leukocytosis that attack the endothelium. It is potent inflammatory cytokines, and we have a couple of isoforms for vascular endothelial growth factor, and the most important one is vascular endothelial growth factors 165. This is the substrates for the growth factors, and it's the expression of vascular endothelial growth factor by retinal pigment epithelium cells, endothelial cells, macrophage, capillary, periocytes, as well malar ganglion and glial cells. In uveitis, we know that there is an increase in aqueous humor levels of vascular endothelial growth factor, as well upregulation of vascular endothelial growth factor patient with uveitis as well. How we can evaluate patient with uveitic macroedema? It is a comprehensive evaluation that includes symptoms and sign, in addition to use the aid of the ancillary imaging modalities like fluorescein angiography, OCT, and OCT angiography. Symptoms of uveitic macroedema, as any macroedema, it leads to metamorphopsia, and this is appreciated if you're giving the patient a Mr. Grid card. It could easily can see the motor. Signs are a lot, and among these signs you can discover by using contact lens examination of the fundus, by looking for the macula, looking for the elevation, blunted of foveal reflex. OCT show how uveitic macroedema is disrupted and can assess the macroedema quantitatively and quantitatively assess the retinal thickness, and can help in diagnosis as well the follow-up of this patient and response to the treatment. Fluorescein angiography, it could help to identify the precise area of vascular leakage. OCT diagnostic criteria for macroedema is characterized by increase in the retinal thickness, flattening of foveal depression, decrease in retinal reflectiveness due to fluid accumulation, and sometimes you might see hyperreflective spots, obliterations of retinal layers, structure with or without presence of cystic spaces. Looking for this really signs are important because this could be unpredictable factors for the visual prognosis in these patients. Another way, OCT pattern is being recognized for uveitic macroedema, and it could be diffuse macroedema like sponge-like, or cystoid macroedema that having an external cystoid macroedema, internal, or even though combined type of cystoid macroedema, or could be presented as serous detachment of neurosensory layers of the retina. If you're looking for the frequency of uveitic macroedema pattern, we can find that a lot of them could be presented with the diffuse cystoid macroedema without serous retinal detachment. It could be cystoid macroedema with subretinal fluid, or could be diffuse macroedema without serous retinal detachment, as you see these figures. And it could be with serous and sometimes just only, as mentioned earlier, serous retinal detachment. And that's important to look for that and to profile this signs when you are looking for patients with uveitic macroedema. Fluorescein angiography, it could help, and assess the blood retinal barrier integrity as whole by looking for focal edema, diffuse edema, or cystoid macular edema, and angiographic scoring of uveitis for uveitis work groups showed that there is 4 categories for fluorescein angiography pattern in uveitic macroedema: either faint hyperfluorescent, that put it as a grade 1, or incomplete ring of leakage, grade 2, or complete ring of leakage, grade 3, or pooling of dye under cystic spaces. How the treatment will be in general in uveitis, we have goals to achieve it when we are treating any patient uveitis, that to suppress the immune system sufficiently to improve the vision or preservation of quality of life, as will prevent additional damage to the eye, make the patient comfortable as quick as possible, and minimize side effects by using the least amount of medication that important to suppress the incident. Looking for uveitic macroedema from other aspects, we have certain identifiable risk factors like intermediate uveitis patients, adults, smokers, uncontrolled inflammation, and intact fetus. This is where the risk factor that could lead the uveitic macula to be more difficult and progress quickly. This is another, treatment algorithm that created by Coronis that and seems very good like that, dividing the uveitic macroedema, either infectious or neoplastic types. And that's really need to be treated by the underlying cause or by control inflammation, or non-infectious uveitis that need to control the inflammation. And then if it is unilateral, you can classify it more to mild or moderate, and then you can use a very ocular steroid, and if failed, then you can go for intravitreal steroids. If the patient having moderate or severe, you can go directly to intravitreal injection of steroid. If the patient having glaucoma, you can use systemic steroid or intravitreal dexamethasone implant. In the other hand, that if the patient having bilateral, the first line of treatment, systemic steroid plus or minus of intravitreal dexamethasone. Second line include methotrexate, Celsip, tacrolimus, or Imuran, or cyclosporine. If that failed and the patient uveitic macula is not responding, you can go more with using anti-tumor necrosis factor alpha like adalimumab or infliximab. And the fourth one is interferon alpha as new medications. In the other hand, in the patient having mild or subclinical type of uveitic macroedema, or that having an acute anterior uveitis, topical steroid or topical non-steroid could be good, effective in this type of patients. So in generally, the treatment of uveitic macroedema include topical and systemic non-steroidal anti-inflammatory drugs, corticosteroid, topical, systemic, transeptal, or intravitreal, or you can use systemic carbonic anhydrase inhibitor or octreotide, somatostatin analogs drug, or using biologic. I will not talk about this. I will talk about that later on at the end of this seminar or this webinar. Non-steroidal anti-inflammatory, as you know, it is this marked reduction in the inflammations when you compare it with the topical dexamethasone drops 0.1% in acute anterior chambers. This is being proven by mass clinical trials. And if you look for the role of for topical systemic non-steroidal anti-inflammatory as adjunct therapy in the anterior uveitis rather than to be the main treatment for the anterior uveitis. And it's been that known the systemic non-steroidal anti-inflammatory in patients with posterior uveitis and macroedema is very limited. This is one of the patients. If you look, this patient is having very clearly having mild vitritis, and as you know that macroedema is more prevalent in a patient with vitritis when you compare it with other type of inflammations. So you're looking for this macula. It is really the reflex is implanted and seem really it is not sharp foveal reflex. And doing an OCT for this patient, it seems that very well there is a lot of cystoid changes involving all the layers of the retina, with as well disruption of the photoreceptors layers. This patient being treated with the ocular, and after a couple of 6 to 8 weeks, his contour of fovea return nicely to the contour of the fovea, and the patient vision improved dramatically in this. We have couple of non-steroidal. We have Voltaren, we have ocular, we have Promodate, and we have Navinac, which are really ineffective. The role of this medication most likely in the post-operative inflammation and post-cataract surgery macular edema. Steroids, as we mentioned, I'm not gonna go because my colleagues will talk about that in details. In general, we have couple of forms of topical steroid like prednisolone acetate, dexamethasone alcohol like Maxidex. We have fluoromethanol, which is weaker steroid, and we have remaxolone in the past that use as less could affect the pressures. When we are treating patient with topical steroid, you have to be careful monitoring for this patient, because this patient might have increase in their intraocular pressure as steroid-induced ocular hypertension and other complications like cataract, as you see in these adjoining pictures. Using this steroid, you have to be careful and to cover this patient sometimes with antiviral to avoid the possibility of herpetic viral keratitis. So this is what I would like to stop here, and later on I can get back to show more systemic treatment for the uveitic macular edema.
Thank you
Doctor.
so much, Dr. Radibi. Just to remind the audience that all the questions will be answered at the end of the webinar. As far as I know, that there are questions, whether raising by hand or typing. All your questions definitely will be answered later after the talk. So our next speaker, Dr. Igor Kozak. He's going to talk about the continuation of the management in uveitic macular edema. Go ahead.
Hi, good evening, everybody. It's a great pleasure to be part of this webinar, and I want to extend my gratitude to Dr. Noura Qasimi for organizing this wonderful webinar, and also to my dear colleagues and friends, Dr. Hassan Dibi and Quan Wen, who are always a great inspiration. I will be talking about local therapy for uveitic macular edema. Dr. Dibi has outlined in detail pathophysiology of the disease, and I will start where he ended, and that is this treatment algorithm for uveitic macular edema. He explained it very nicely in detail. So there is an indication for eyes to receive local therapy, usually when topical therapy is not helping, and when systemic therapy can sort of wait. So what is the rationale for local therapy in uveitic macular edema? It's to allow for selective therapy of selective uveitic entities to deliver a highest concentration of the drug at the site, of course, to avoid damage to nearby and distant tissues, and to avoid systemic exposure. In principle, from drug delivery point of view, there are two ways to treat macular edema locally, via periocular or intraocular injections. So periocular steroid injections are indicated for patients with severe or poorly responsive uveitis that is refractory to topical or systemic treatment. Patients who are non-compliant for topical or other forms of local therapy. Unilateral patients are better candidates, and it's because this type of treatment reaches behind the iris lens diaphragm in comparison to topical application. Now, the techniques for periocular injections include subconjunctival injection, subtenon application, transeptal or orbital floor injection, as it used to be called, or even retrobulbar injection. And so what is important for all these ways that we deliver the drug is basically transscleral drug delivery. So anything that we inject as a periocular injection actually has to pass the sclera in order to exert its effect. And when doing so, all these are very important. That is molecular weight of the drug, radius, drug solubility, scleral thickness, of course, and even intraocular pressure in the eye. These are very important factors that will influence the success of this treatment. So we know that the sclera is basically a conglomerate of fibers, elastin fiber, collagen, collagen type. They are organized in a way that are basically highly disorganized. And for that reason, unlike cornea, the sclera is not transparent. Now, very important, from local anatomy is that equatorial region has the high level of hyaluronic acid, whereas bacular region has highest level of chondroitin sulfate in its composition. And then there is dermatan sulfate that is present in the region around the optic nerve of the sclera. So the most important of these and the most abundant is hyaluronic acid, which fills in the gaps in the sclera. And actually, this is a study of human enzyme that breaks down hyaluronic acid and opens the spaces in the sclera, therefore enhancing the penetration of the drug that is injected as a periocular injection. And this is its molecule. And these are some animal data from our experiments showing the penetration of dexamethasone, labeled dexamethasone, throughout the whole scleral wall and the structures underneath, such as suprachoroidal space, choroid, and even subretinal space, the retina and the vitreous. And these are pharmacologic curves of what happens with injection when you inject it in periocular space and has to travel through the sclera. In relation to time, we see the levels in the cornea, in the choroid, in the retina, and the vitreous humor. So after the initial high concentration, then this concentration of the drug gets washed away. So in subtenance injection, it's performed either preferably in supratemporal or infratemporal quadrant. We need to find the space, subtenance space. We can even use small Westcott scissors to open the space and then safely deliver the drug in the space. And this is some demonstration of it. Transeptal or orbital floor injection, usually larger bore needle. We want to stay away from the muscle cone. There is noticed less drug penetration in the posterior segment, but yet it is an effective way to use this local treatment. Here is a list of steroid preparations that we are using for treatments such as methylprednisone, triamcinolone, dexamethasones, which are most commonly used. Usually in our clinics, we use the triamcinolone or Kenalog, which comes in 40 milligrams dosage, or methylprednisone acetate, which is used for orbital floor injections. Kenalog can be injected intravitreally. Based on the technique, we can use either a high or low dose of Kenalog. Traditionally, Kenalog has been studied in concentration of 1, 2, or 4 milligrams, but we can actually use high dose by technique so-called decanting or decantation, where we remove the supernatant and then just inject pure crystals. What are the limitations of periocular steroids? Still, bioavailability is variable. The effect of the drug
Dr. Igor? Dr. Igor? I think the connection is interrupting, so your voice gets interrupted.
Can you hear me now?
Now, yes.
Okay. So just to repeat that some of the limitations of periocular injections is transient effect of the drug, and there are complications or potential side effects. These complications can be related either to the injection technique, such as blepharoptosis, orbital fat herniation, hemorrhage, or damage to nearby structures, or it can be related to the drug itself, such as development of posterior capsular cataract, formation of fibrosis, atrophy, secondary glaucoma, skin discoloration, which has been seen, and others. Contraindications of periocular steroid, and my colleagues will touch on that, is definitely infection infectious uveitis of any etiology, some scleritis, and the history of induced pressure or glaucoma. After periocular injections, let's move on to intravitreal injections. It has somewhat prolonged release. It is more targeted treatment for uveitic macular edema. And apart from corticosteroids, actually, we can use other agents to tackle the disease and inflammation. So what are the indications? Again, resistant uveitis that is resistant to conventional therapy, systemic complications of treatment, refractory macular edema, or prevention of inflammation recurrence following cataract surgery. And here is a scheme of what happens when we inject a drug in the vitreous space. So the drug molecules can reach the retinal tissues from the vitreous, and this is how they are cleared from the vitreous cavity. Large hydrophilic molecules leave through aqueous humor and anterior chamber, whereas posterior clearance is more important and usually occurs via high choroidal blood flow through the posterior segment. Now here is a photo of intravitreal triamcinolone injected for uveitis, and then it can be either dispersed or concentrated as demonstrated on ultrasound on left panels. An example of successful treatment of uveitic macular edema following intravitreal injection. So what are the limitations of intravitreal corticosteroid injections? Again, transient efficacy, even though there is some decent timing reported with this treatment. Of course, things depend on the concentration of the drug, on whether the eye is vitrectomized or not. And so all these can contribute to success of the treatment. And again, there may be cumulative damage caused by recurrent inflammation because we have gaps in the treatments. Then drug-related complications such as infectious or sterile endophthalmitis, formation of cataract or retinal detachments, which are rarely seen. Aside from injections, we can use implants that are injected in the vitreous cavity, and very common is the dexamethasone intravitreal implant, 0.7 milligrams Ozurdex, which is biodegradable. And here we can see the matrix, which contains the dexamethasone molecules, and with the presence in the vitreous cavity, there is a steady state release of dexamethasone molecules until the whole implant breaks down, and there is no more release of the drug. So this study was used to compare two concentrations of dexamethasone in comparison to sham in cases of non-infectious posterior uveitis, and clearly has shown superiority of this treatment in comparison to sham. Another trial compared intravitreal triamcinolone, dexamethasone, and periocular injections. And while all of these treatments were able to reduce retinal thickness, there was a significant difference between periocular injections and intravitreal injections favoring intravitreal drug delivery. And these are the data from 6 months follow-up. Another implant is a Retisert implant, fluocinolone acetonide, that was approved by FDA for treating non-infectious uveitis. Its approval was preceded by some rigorous clinical trials, and this is how the implant is anchored to the sclera in pars plana area. So unlike other implants, it's not injectable implant, it's not injected in the vitreous cavity, it has to be sutured, and it stays there until the pellet stops releasing the drug, which may be up to 3 years of observation. Pivotal clinical trials performed in the United States and elsewhere randomized the patients, and Here we can see the number of lines following the implantation of Retisert implant. This is a very potent treatment, however, is associated with numerous complications, and here they are: formation of cataract, increase in intraocular pressure, or formation of glaucoma, requiring even filtering surgery procedure. Then we move on to another treatment modality in uveitic macular edema, and while not primarily targeting the inflammation, anti-angiogenic agents can also be successful in treating uveitic macular edema, and also if this is associated with choroidal neovascularization, which is of inflammatory origin, but these approaches have been shown to decrease intraretinal fluid quite efficiently, and they may be a good resource in some of the eyes, for instance, eyes with glaucoma, in which steroid treatment is not a good option. So some of the complications that are pertinent to triamcinolone or anti-VEGF or to both. And these are quite known. Now, some of other approaches include intravitreal injection of different molecules and different approaches, mainly to tackle the posterior uveitis and vitritis. However, this frequently goes hand in hand with uveitic macular edema. And these drugs have also shown efficacy in reducing inflammation and macular edema, and therefore improving the vision. Intravitreal injection of methotrexate is one of that. Methotrexate is an anti-metabolite that inhibits the hydrofolate reductase and therefore DNA replication and RNA transcription, and was first used in intraocular lymphoma, but has also switched its use into intraocular inflammation. Of course, repeated injections may be needed because of similar pharmacokinetics that was shown with the steroid treatment. Now, intravitreal sirolimus is a very interesting approach, actually pioneered by Dr. Kwan, who is here today with us. Sirolimus is a macrolide antibiotic that basically inhibits interleukins, was used for non-infectious uveitis. Different dosages have been studied in SAVE trials, SAVE 1 and 2, and then in SAKURA clinical trials, have demonstrated efficacy in reducing vitreous haze and also with macular edema. Intravitreal infliximab is also another approach to address uveitic macular edema, usually refractory. Infliximab, we know, is a biological agent. It's a chimeric monoclonal antibody against tumor necrosis factor. This is the dose of it, and it has been used quite extensively in Behçet disease to quiet down inflammation and also associated macular edema. These treatments give us opportunity to help these patients. However, there are failures with this treatment, like with other treatments. And the reasons for treatment failure may include lack of disease stabilization. We just don't quiet the disease enough, and it continues to be active. Or we quiet the disease, but then the disease recurs, which is the nature of many inflammatory diseases. Or there is just no vision improvement in spite of anatomic improvement, or this treatment will give severe side effects to patients, and it has to be stopped. So these are common reasons why sometimes this treatment may not be helpful. Let me mention another treatment, and that's an Iluvien implant, which is fluocinolone implant that has been approved initially for treatment of diabetic macular edema, but has now been also successfully studied in clinical trials for posterior uveitis, non-infectious uveitis. And I would like to briefly show you a case of a female patient who had been treated systemically for her posterior uveitis, and because of enrollment into IVF program, she stopped with her systemic treatment and instead was treated with Ozurdex implant with very good response. However, with a short time of when she needed a repeat implant. And when we saw her first time on presentation, her vision was 616 right eye, which was her worst eye, 612 in the other eye. And here are the pictures. So we can see lots of vitritis on top of old chorioretinal scarring, and this was before implantation of this long-term fluocinolone acetonide implant, and this is vision improvement after bilateral ILUVIEN implant. We now have much better view to the retina because of decreased vitritis, and then there is an improvement in uveitic macular edema that was associated with her underlying disease. So this patient actually continues to be doing well for 18 months. And with that, I would like to thank you for your interest and for your attention. And I would like to give the floor back to Dr. Noura.
Thank you so much, Dr. Igor, for reviewing the different aspects in local intravitreal and local therapies. Now, I know that the bulk of the management of uveitic macular edema, the master of the management is intravitreal. So we are going with Professor Kwan for continuing the different aspects also of the management locally. Professor Kwan, the mic is all yours.
Good morning, good afternoon, and good evening, everyone. It is my great pleasure to be joining Dr. Hassan and Dr. Igor on this symposium. A very sincere thanks to Dr. Noura and the Emirates Society of Ophthalmology for having us involved in this program here. What I hope to share with you over the next few minutes or so is what we learned so far in managing our patient with uveitis. How do we avoid cumulative damage that occurred after attacks and recurrent attacks, as well as the potential way for us to utilize a certain type of treatment, but be aware of the potential risk for ocular hypertension and glaucoma. My disclosure is listed here in the slide for the various work that we have been involved in. So in managing ocular inflammatory disease and uveitis, one needs to be aware of the concept of cumulative damage in uveitis. In most forms of uveitis, the visual morbidity usually does not occur from just a single episode of uveitis. Rather, recurrent episodes of inflammation can cause excessive cumulative damage. The first time a patient has an attack of uveitis, one treated and the visual acuity often will return to 20/20s. However, after multiple episodes and treatment, at one notice, the visual acuity, for example, continued to drop slowly, 2025, 2032, 2040, and so on. So that's what we have seen in our clinical care. Some of the questions remain, however, are how many episodes must recur before cumulative damage occurred, and what is the minimum duration of each recurrent episode? This fourth figure represents what an eye can look like in the various types of cumulative damage that occurred. In the upper left, that is the case of lupus-associated chorioretinopathy after meningeal attack. In the upper right-hand corner, that's what an optic nerve and the vessel look like with many attacks in ocular Behçet disease. In the lower left is the case of sarcoidosis that have had multiple recurrent attacks. And in the lower right, the big audible inflammation there, that represents a case of granulomatosis with polyangiitis aspect from there. So each of these four clinical scenarios show to us what happened when we let recurrent inflammation occurred one episode after another. Multiple studies have also indicated to us that there are prognosticators for visual outcome in uveitis. Certainly, a delay in presentation to a subspecialist, the total duration of uveitis, the presence of intermediate or posterior uveitis or panuveitis, the number of recurrent episode of inflammation, development of cystoid macular edema, which is the theme of these meetings, development of glaucoma. So how do we define this? As a way, I thought that Fallon Sensen well described this. The total insult incurred, which may be greater than the sum of individual insults as a result of repeated inflammatory attack on tissues, organs, or other body structure that often lead to irreversible consequences. When we look at the inflammation, just as in the movie, we can look at the good, the bad, and the ugly aspect of this. First, our tissue, the normal tissue homeostasis is quite strong and is maintained by the resident macrophage. With attack of inflammation, we see potentially tissue damaging macrophages that functionality is too initiated due to the damage, the infection, and the autoimmunity. That's when inflammation occurs. And then followed with that, you have failure to downregulate the initial response that then results in the chronic pathogenesis and tissue damage. And of course, this is where we may not be able to get reverse stage. Eventually, the healing occurs, but by that time, a lot of the tissue have already damaged, leading to functional disability. This is a simplistic curve, but it illustrates the point very clearly. The red curve, the sinusoidal, is representing the inflammation, or rather the recurrent episode of inflammation. The cumulative damage is the blue curve. So as one can see, with multiple events of inflammation, the red curve go up and down with attack, control, attack, control. Every time just recurrent attack occurred, the cumulative damage continued to rise. So eventually you will have a significant amount of cumulative damage that occurred. It certainly, the damage can be quite devastating consequence of posterior uveitis. This is a case of the patient that initially presented to me with this type of picture in the upper left of a case of ocular sarcoids, as you can see with some granuloma, some vitreous cells. The patient was advised of the certain treatment program. However, because of various reasons, the patient did not return to the clinic and was treated locally by the local physicians with various type of local therapy. And then he returned about 18 months later with this type of inflammation of the eye in the lower right, where at this time you have significance of the damage to the retina and the choroid, and suddenly leading to impaired vision. As clinician and clinician scientists, we definitely do not want to see this pathway. We want to keep our patient and their vision and their eye as in the upper left and not in the lower right image where damage has already led to significant loss of vision. Chronic inflammation is associated with ocular damage and posterior uveitis, and this has been shown to a number of aspects. Certainly, the topic for today's symposium, development of cystoid macular edema and uveitis, is definitely one of the reasons. Development of neovascularization in the pediatrics intermediate uveitis, and development of neovascularization, whether retinal or choroidal, cataract formation, and retinal detachment. These are all the potential damage that can occur with chronic inflammation. You have heard Dr. Igor just mention about some potential treatment, and one of which is with the fluocinolone acetonide insert, the 0.2 microgram per day under the trade name of Iluvien. This particular type of steroid has been demonstrated already to work quite successfully in another product called the Retisert, which is also a type of device, but instead of an insert in the office, it's rather an implant in which surgical intervention is needed. with its subsequent risk of significant increase in intraocular pressure, which we'll discuss. So that now one can think of ILUVIEN or the fluocinolone acetonide inserts as the newest generation of steroid device that can deliver with very stable molecule, long-acting efficacy with strong anti-inflammatory activities, and is also the release for up to 36 months of that in this aspect. Certainly right now, the fluocinolone acetonide inserts under the name of ILUVIEN is indicated for the prevention of relapses in recurrent non-infectious uveitis affecting the posterior segment of the eye, including uveitic macular edema. There have been several studies to illustrate the potential role of the fluocinolone acetonide insert. One particular one is the O1 study. In this study, there was a significantly fewer recurrence within 36 months, whereby the insert has 1.7 recurrences versus in the control that have over 5.3 recurrences. There's also a much longer time to recurrence, 657 days for eyes that had the inserts compared to 70 days for those in the control group. In addition, there were less adjunctive treatment and a much larger improvement in best corrected visual acuity. There was also a lower rate of intraocular pressure lowering surgery and the rate of cataract surgery in the inserts group. So those are some of the brief data. What are the lessons that we have learned from clinical practice using this fluocinolone acetonide insert with the release of 0.2 microgram per day of the steroid? There are some key learning points. First of all, patient selection is extremely critical. In that is, we see want to make sure that these are usually cases of chronic sight-threatening posterior segment uveitis that usually associate with intermediate, posterior, or panuveitis. Unilateral or asymmetric disease are usually good candidate for this particular device. The ocular disease should drive the treatment decision. I repeat, in this type of patient, the ocular disease should drive the treatment decision. In other words, let's say a patient has sarcoid and the patient has been quiet in terms of systemic therapy, and right now it is only the ocular disease that is the dominant factor, then yes, the use of the acetonide insert would be a wonderful choice. On the other hand, if the patient still have active pulmonary disease or dermatologic disease from the sarcoid and still requires significant amount of the systemic treatment, one cannot expect just to use the fluocinolone acetonide insert to control the whole disease for this aspect. Other consideration would be disease responsive to steroids and compliant, very important, compliance with follow-up, which is aspect from there. Some benefits that occurred has been the sustained control of ocular inflammation that can be up to 36 months, the avoidance of cumulative damage from repeat cycle of inflammation. In other words, our goal in placing one of the steroid device in the eye so that there will be very stable chronic control of any inflammation so that you would not have that sawtooth pattern going up and down and therefore preventing cumulative damage from occurrence. In addition, there's reduced need for adjunctive treatment and minimal systemic side effect from that aspect. So one can discuss with the patient and discussing the voice of using systemic therapy, including hepatotoxicity, renal toxicity, and then discuss some of the potential side effects of the treatment with the implant or the insert to see which one would be most appropriate for the patient. There's some disadvantage with this fluocinolone acetonide insert. That is, there's risk of cataract, there's risk of ocular hypertension and glaucoma, and again, after 2.5 to 3 years, if the disease is still active, one may still need to provide or place another insert in the eye. What exactly are we can consider in our clinical daily practice of this? So let's look at some practical consideration. When we talk about putting steroid in the eyes, all of us on this symposium and throughout the world, one of the first concern we have is that what happened to the intraocular pressure? After all, that is the most important concern that we have, managing patient using steroids. Cataract, we can correct, although inconvenient, but we certainly can correct. But ocular hypertension and glaucoma is something that we're very concerned. So fortunately, the data from the 001 study is quite strong. And this graph showed you the mean intraocular pressure through 36 months having the fluocinolone acetonide insert inside the eye. The black curve at top, that represents the subject who were randomized to the insert, and the orange curve is the randomized with the control. And as you can see, the pressure very little throughout, and it did not go up more than about 16 or so in that throughout the 36 months of this regard. So the mean IOP by visit throughout the study was quite important and illustrate that the pressure concern was not significant at all when we put in it. Again, the patient need to have follow-up and make sure that is stable, but so far data have shown that the intraocular pressure has remained relatively stable when we place one of the fluocinolone acetonide inserts. So what are some of the appropriate cases for long-acting steroid implant and inserts in here? First, the disease expect to recur or persist for more than 2 years. If you just have a case, or if we just have a case of unilateral anterior uveitis that we expect to be controlled shortly, that definitely would not be a good candidate for this steroid insert. So therefore, the disease should be expected to recur or persist for more than 2 years. It should be the ocular disease that drives the treatment decision, not the systemic disease. A third consideration would be intolerance of or non-responsive to standard therapy. And the fourth would be certainly sight-threatening disease that therefore give us the indication to consider it. Other appropriate situation would be no previous intraocular pressure elevation to steroid, or be prepared to manage the ocular hypertension very well, including to have glaucoma surgery. The subject, at least significantly, should have no severe glaucomatous nerve damage, so that, especially if the patient is monocular. And the third aspect would be that the subject, very importantly, need to comply with follow-up even when the uveitis is quiet. And that's very important to emphasize to our patient with that aspect. What are some of the inappropriate cases for long-acting steroid device, such as the fluocinolone acetonide insert? First, obviously, cases of infectious uveitis should not be considered. Cases of masquerade with an underlying malignancy, for example, should not be considered. Cases in which ocular disease does not drive the treatment decision, that should not be considered. And that if the patient has been non-compliant and you say, well, since you've been non-compliant, I'm just going to put an implant on you to make sure that it's under control. That is a bad decision, because if the patient doesn't come back for his or her regular checkup, you may have an eye that have rise in intraocular pressure, and then you will lose vision from that. So for this part of talk, choosing the appropriate treatment option in here, again, acute disease does not require long-lasting treatment, such as the fluocinolone acetonide insert. On the other hand, chronic recurrent disease should not be treated with repeat short-acting like intravitreal triamcinolone, for example, that keep leading to recurrent episodes of the disease, which lead to cumulative damage. So that's certainly an important factor. Now, I'm going to move to the next part, final part here, and discuss a little bit aspect about managing the ocular hypertension and glaucoma in uveitis patient receiving steroid device, because as I mentioned, after all, this would have been the only type of any potential concern when one consider the use of a steroid, intraocular steroid device or implant in patient with uveitis. So some of this data has been helpful when we look back at some of the old data. As I mentioned, the research also contained fluocinolone acetonide in that, but it's about 3 times the molar of the amount of milligram of steroid compared to the Iluvien, which is the insert. The research required a surgical procedure to place the implant, but a lot of that, the study that we look at right now in terms of intraocular pressure, we are very fortunate to have the data from the research to help us drive. For example, Data from study revealed that intraocular pressure elevations occurred in approximately 65 to 75% of eye that have had the Retisert implant. So that's definitely a lot higher than what we see right now with the Illuvian. 50% of implanted eye reach at least an IOP of 30 by 3 years. Again, that is not what we're seeing right now with the Illuvian. We see a much, much lower rate. At least 70% of implant eye required IOP lowering medication within 3 years, and 30 to 35% of implanted eye required glaucoma surgery. Again, these are the number for the Retisert, and fortunately, now with the Illuvian, we see a much, much lower number, and our patients are not at the same level of risk. Beyond having the steroid inside the eye, when we manage our patient with uveitis, all of us recognize that the patient, regardless whether they have steroid or not, can also be at risk for intraocular pressure elevation. So this is the fellow eye that result in the Retisert study. That fellow eye did not receive the Retisert, but again, 25 to 20% of the fellow eye developed IOP of higher than 10 mmHg over 3 years. 36% require IOP lowering medication, and 2% require glaucoma surgery. So one can think of this so very much like the baseline risk of eye with uveitis, regardless of whether the eye has or have not received any type of steroid device. IOP elevation in uveitis range from anywhere between 11 to 46%, and this comes from one of the earliest study that came out in 2004, with the number, I say 34% of the patient with chronic uveitis has IOP elevation requiring treatment. Subsequently, in 2009, another paper came out and showed that 90% of eye with IOP elevation from uveitis need treatment from this aspect from there. So again, this illustrates to us that regardless of what we do, eyes with uveitis are at risk for developing ocular hypertension and glaucoma. Hence, the term uveitic glaucoma also occurred. So just data, what can they help us? What does this mean for a potential patient with intraocular steroid implant or insert? What should we do as clinician scientists to be able to manage this patient? Well, first, this data help to explain the risk of the fluocinolone acetonide insert, the Illuvian, or the implant, the Retisert. They also help to explain the high risk of elevated intraocular pressure in patients with uveitis, and that the risk of visual loss is still real from glaucoma, and therefore we require close management. Certainly, such risks are much higher with the Retisert than with the Illuvian that we're currently considering. What do we do, or what should we consider in patients prior to us putting in the fluocinolone acetonide insert in the office? First of all, we should have good documentation of the intraocular pressure coupled to this ratio. We should definitely obtain the color disc photo and possibly a baseline visual field as well. And we should also evaluate other potential causes of glaucoma, such as chronic angle closure from the syncytiae that occur from chronic uveitis. In patients with history of steroid response or diagnosis of glaucoma, perhaps we should also get our patient to see a glaucoma specialist before we put in one of the fluocinolone acetonide insert. The optic nerve imaging and pachymetry using OCT device and other devices should be obtained or may be obtained in those patients with ocular hypertension, elevated cup to this ratio in glaucoma. Again, the goal for us as the caring physician for patients that we do not want to treat one disease for another, and therefore we want to provide our patient with the maximum care looking at multiple aspects. In addition, we should have a very thorough discussion with the patient about the need for regular intraocular pressure monitoring, even after 1.5 or 2 years after implantation. So please do not forget about the patient and the patient return for follow-up. Discussion with patient about the risk of vision loss if IOP elevation is left untreated, and coordination of care with local ophthalmologists if the patient lives far away and cannot come back to a major eye center regularly. Finally, for the post-placement patient with fluocinolone acetonide insert, what do we do once we put the insert already inside the eye? So certainly we should have regular IOP monitoring either do it ourselves or have one of our colleagues help locally if necessary. We should have aggressively treat the ocular pressure elevation, especially in high-risk patients. Our study have shown that 50% of patients who receive the Retisert would be on IOP lowering within 6 to 12 months. Definitely, we should keep that in mind, but also understanding that the study with the Iluvien thus far demonstrate a much better safety profile than what we have seen with the Retisert. The IOP elevation may still occur 2 to 3 years after the steroid device, and so therefore, as a last sentence, please do not forget about this patient and the intraocular pressure, because we want to save the vision from uveitis and also from any potential problem with ocular hypertension and glaucoma. And with that, I thank you for your attention. And again, a sincere appreciation to Dr. Nurat and the Emirates Society of Ophthalmology, Dr. Hassan and Dr. Igor for having me involved with this across the oceans. Thank you.
Thank you so much, Doctor. We are honored to have you this evening in our time. And thank you for talking and explaining the implants in depth and the side effects and how to manage it. With our next speaker is Dr. Hassan Adibi. And just to remind all the audience that we are willing to...
We cannot hear you, Dr. Noura. We cannot hear you.
Can you hear me right now?
Yes.
Yeah.
Now
okay.
We can.
So thank you so much, Professor Kwan, regarding tackling all the intravitreal implants and talking the types of it in depth, and even tackling the management of raising intraocular pressure. And reminding all the audience that the questions we are happy to answer just in coming a few minutes after Dr. Hassan's talk. If you have any question, you can write it in the Q&A box or raise your hand so we can open the mic for you. Dr. Hassan, we are waiting for your talk.
Okay, thank you, Doctor, and great talks from both distinguished speakers, eminent. And actually, treatment of epiphytic macroedema, as we said, it is really integrating with topical, local, and as well systemic treatment. So the treatment of epiphytic macroedema is evolving, and in the latest year that it's an essential part of treatment of uveitis cells. So the first part of treating any epiphytic macroedema is that to suppress the intraocular inflammation aggressively. So systemic treatment is a part and cannot be eliminated from the algorithm of the treatment, and that a lot of the medications being used in that, including the systemic steroid, in addition to immunosuppressive and immunomodulatory drugs. So mycophenolate mofetil has been used and showed that really success rate in this treatment, apart from the suppressing the inflammation and improvement to the treatment. We have systemic methotrexate, either oral or subcutaneous, has been shown that in the reports it is really helpful in the management of epiphytic macroedema. Another new medication just introduced in the previous decade in the treatment of epiphytic macroedema is the biologic, either systemic or intravitreal, as mentioned in the previous talk. So among the common medication that been under trial and used in the retrospective manners is the interferon alpha 2A and interferon alpha 2 as one of the immunomodulatory medications, and showed actually a good result, especially in the patient that having Bahja disease that associated with epiphytic macroedema. Another type of biologics is the tumor necrosis factors alpha inhibitors that being used widely in our era nowadays, including infliximab, and showed really a good and excellent options for treatment of patients with refractory type of intraocular inflammations, and showed very good result in epiphytic macroedema response. In addition to that, we have adenomab, that one of the biologics that FDA approved for the intraocular inflammations, and we compare it with off-label medications, and showed systemically at subcutaneous and as well intravitreal some really promising result as well. We have another anti-interleukin 1 beta, givasogumab, is being used in the trials as well on the anecdotal reports, and show some benefit, but not that as with other medication. We have another biologic, tocilizumab, anti-interleukin 6, and showed as well certain success rate and improvement. Daclizumab is really being used in certain patients and showed good response to the inflammations, but when are looking from the macroedema, actually is not effective as the previously. Rituximab being one of the powerful medications used especially for scleritis and intraocular inflammation, but anti-CD20, but actually is not that really effective as the previous. And lastly, we have aflibercept, anti-CD11 is one of the medication being used in the practice to use this medication in general. It's cannot be used as a first line of treatment, but could be used as the second or third. As you know, this is cost effective, and this is really biologic treatment that targeted to the certain types of inflammation. So if you're looking, we have a lot of evolving and a lot of research in that, but till now we don't have really one of them that showed that really significant treatment over others. So we have to keep that in mind. Option of this medication is helpful, especially when we have a refractory resistant uveitic macro edema not responding to all modalities that will be mentioned in this webinar tonight. If you would like an interesting to know all the details of the studies and the clinical trials, you can get back to the reference of Corinis. It al. Showed really good tables, summarize all this type of medications and biologic that by the time being in the practice for treatment and under trial to see the efficacy and safety in the treatment of uveitic macroedema. So this is in general the treatment options that are available for treatment of the uveitic macroedema. The essential part to suppress aggressively the intraocular inflammation is the first role in treatment of uveitic macroedema, in addition to adjunctive treatment by non-steroidal steroids, and even though the systemic treatment or intravitreal implant as mentioned by Professor Kwan. Looking for the prognosis of uveitic macroedema, untreated uveitic cystoid or uveitic macroedema tends to cause progressive injury to the macula and visual loss, and the visual loss related to uveitic macroedema has been associated with photoreceptor permanent damage, irreversible macular ischemia despite resolution of edema on OCT and fluorescein angiography. And the end stage of uveitic macroedema characterized by thinning and fibrosis of the retina, refractory to medical treatment, and carries a poor visual prognosis. What are the factors could predict the prognosis of uveitic macroedema response to treatment? The type of uveitis entities, as more posterior type of uveitis like panuveitis or intermediate uveitis showed more really poor prognostic factor. Duration of uveitis, as long as patient having uveitis, as mentioned by Professor Kwan, repeated a cumulative effect, it might lead to permanent damage of the retinal pigmented epithelium, photoreceptors, and then the mechanism of bumping and drying of the macula is being stiff and cannot be easy back to the normal. Then the age of the patient, older patient having less or predicting the prognosis is not as that young patient. OCT thickness, as the thickness is high, more than 500, 600, is really one of the predictive factors. As well, the increase of vascular foveal vascular zone, as this is indicating of capillary dropout and decrease the blood supplying to the macro area, it might be interfere with the prognosis of uveitic macroedema. And then presence of vitreomacular traction and epiretinal membrane, as you know, this is more surgical. Chronicity of this might be permanently affect the response of uveitic macroedema. So indeed that previous studies documented various prognostic of the poor visual outcome in uveitic macroedema, including the prolonged duration of the uveitis and CME itself. So that's important to discuss it to your patient at the beginning of the treatment of uveitic macroedema, putting in your mind that quiet and inactive uveitis anteriorly and posteriorly. Prolonged duration of the uveitis and activities is really actually, it could by itself affecting the prognosis of the uveitic macroedema. And large foveal vascular zone, as we mentioned earlier, the presence of complete vitreous detachment and epiretinal and other factors, and increased macular thickness, diffuse macroedema pattern, and OCT, and the advanced age of the patient. And indeed, as well, the OCT having a lot of biomarkers that could help you to see the prognostic factors of uveitic macroedema, including hyperreflective spots that present in the combined type, diffuse, cystoid, and serous retinal detachment is really showed. And the other thing is that even though the loss of the photoreceptors and really thinning of the retina in general. So these things together, put it in your mind when starting treating your patient, and then you can plan your treatment options. And even though that you know how much in the beginning, you need to do all your parameters, OCT, fluorescein angiography, OCT angiography if you have it, and really evaluate the patient accurately as a baseline. Then you can proceed your treatment, and then you can monitor your patient by OCT to know how much of this patient in thickness and even the visual acuity. So in conclusion, uveitic macroedema represents an important vision-threatening disorders occurring in the course of the various uveitis disease, and it is associated more commonly with more posterior located uveitis, like intermediate uveitis, posterior and panuveitis, and untreated uveitic macular edema tends to cause progressive injury to the macula and visual loss. And fluorescein angiography and OCT are essential in evaluations and follow-up of uveitic macular edema. The combination of intraocular inflammations with topical periocular intravitreal steroid and anti-vascular endothelial growth factor are the recommended treatment of cases of uveitic macular edema. And lastly, I would like to thank you all. Special thanks for you, Dr. Noura Al-Qasimi, for giving us this chance to share our experience and to participate in this webinar. And thanks as well for my colleagues, Dr. Professor Kwan and Dr. Igor Kozak. Thank you all, please.
Thank you, Dr. Hassan Al-Dibi, for your talk, and thank you so much, our dear speakers. Regarding the, let's talk about, when you said about the vitreomacular traction, what's your opinion and when do you interfere for vitrectomy, Dr. Hassan,
Yes.
for as a visual prognosis?
Yes.
Yeah.
This is an important when I said that in the early part and basic work for the uveitic macroedema to do an OCT, and this is essential to show you the relation between the vitreous interface and the retina. So sometimes you might have just only vitreomacular adhesions, which is really not affecting the contour of the macula. So trials of intravitreal steroid, either injections or implants, or sometimes anti-VEGF, it could help to release this and lead to posterior vitreous detachment. In cases that persist and the macroedema thickness is high, this is where might be an indications of vitrectomy. Patient with vitreomacular VMT, which is abbreviation for vitreomacular traction, and from the beginning you can say that is it broad base or just only single base. If it's just only small centers, then you can try this options and it could be released easily. If not, immediately you cannot wait and go for a vitrectomy, which is give you. The problem with that vitrectomy, sometimes you are using the vitreous gel as a professor for areas that to contain the medication, so that give it time to be released and helpful in the making the duration of the release treatment longer. But if it is the reasons for the the pathology, it's really indeed need the treatment.
Okay. Yeah.
Just along with.
Yes, Prof.
Just along that line, for any of us who have ever peeled membrane from uveitic eye, just please be patient. This membrane would usually cause traction enough and cause edema, Dr. Hassan had mentioned. usually do not come off so easily as in, let's say, an epiretinal membrane in an elderly individual without uveitis. They usually come up in pieces, and because they're very sticky and adherent to the surface. So just have some patience, because you shouldn't expect, or it often does not come up at one nice piece as we see in senile epiretinal membrane, but rather they come in different pieces. And so just have patience, and eventually you will get most of them off.
Okay. Talking about the topical, I received a couple of comments from Dr. Avinash and Dr. Qasim Al-Hamouri regarding the topical steroid, which is difluprednate. Prof, do you use it? Because they said it's really a magic drop, and as I know that it is really helpful for the uveitic macular edema. Tell us about it.
So my experiences with topical difluprednate is average. It's not, definitely is not 100% successful. And I have come into the style in which, if I were to start the patient on topical steroid for macular edema from uveitis, I often also use it in combination with a non-steroidal as well. So I combine both the topical steroid and the topical non-steroidal drug in there because my success rate with topical difluprednate, and that's been shown as well too, is not very high by itself, especially cases that often get referred to us at the academic center where it's been on for a long time. So you definitely should consider it if you need to, but if it doesn't work quickly, and I usually give it about 8 weeks or so to begin to see some effect. If you don't see it, you either should add a topical non-steroidal or use it from the beginning or change in a different approach.
So you combine both for the
Yes,
maximum.
I combine both. It is very, very rare. In fact, I don't recall the last time I actually do this, where I just use the topical steroid alone. Because we know non-steroidal have a different approach, usually to the COX inhibitor path aspect there. So it's better when you use multimodal approach to control this, and I think that would be appropriate. I don't know, Igor and Hassan, do you typically use at the same time too, or Dr. Nora, or you use them sequentially?
Yeah, myself, I'm using that as a combinations. I'm really a little bit cautious when I'm using non-steroidal for a long time because it's not free of side effect, and it could affecting the retina and lead to melting. So we have to be careful. The new generations of non-steroidal anti-inflammatories, it showed really in the practice and in the trial some effect in the uveitic macro, but I'm not using that for uveitic macro that would increase central macro. Some uveitic macro in the range of 350, and that could help. But cases with the very having cystoid, uveitic macro edema, or central macro thickness of more than 400, 500, the effect of non-steroidal is usually limited, even though the topical. I don't know about Igor.
Yeah, I'm usually more aggressive, and if I use topical, I usually use it in eyes that show some macular edema, but the vision is still good. I am just paranoid about, inflammatory activity in the macula, and also my threshold is quite low. I do not continue this type of treatment for more than 4 to 6 weeks. That's like maximum. If I don't see effect within that period of time, then I switch to more aggressive treatment.
Yeah, for myself, I see the eye overall and how the patient should be aggressive, as Dr. Igor said, because uveitic macular edema is sometimes according to the visual acuity and even the thickness. So I can so I evaluate the eye itself overall for initiation the steroid, and how frequent shall I apply it, ask the patient to apply it per day. But I don't prolong that much. The problem is that there is a refractory, and here the scenario differs, goes to another way.
One other approach that we have not heard a lot yet today, which I thought actually very helpful cases, is the use of carbonic anhydrase inhibitor, either topical and or systemic. And a lot of time now I move to systemic. So the use of, for example, acetazolamide or any of the topical version, I wanted to find out what is our colleague experience like. Certainly, my experience has been quite well. Again, not 100%, but oftentimes I use it before I move on to, let's say, a biologic or a steroid, is to use a systemic carbonic anhydrase inhibitor. Again, take into account all the potential side effects with the systemic CAI, including, for example, hypokalemia. So, but we are thinking of it in terms of a short term, definitely not a chronic treatment. So I'm curious to see the three colleagues here, Dr. Igor, Dr. Hassan, Dr. Nora, what are you using them at all, or where in your chain do you use amid all the choices we have?
Okay, let me start regarding the CSR due to systemic steroid in a uveitic patient. There are some couple of patients that I saw that developed CSR due to steroid. Here, the Diamox or the carbonic anhydrase inhibitor tablets, I initiated as a medication for the unfortunate patients due to CSR. So this is the thing that my next question for you regarding the Diamox or carbonic anhydrase in patients with CSR due to steroid intake in uveitic patients.
So if it's a CSR situation, yes. So first of all, if I determined that is due to that. So first of all, the first thing one would do would be obviously to try to stop the steroid, yes, because we definitely don't want that inciting thing. I have used several times the CAI with to treat that to the CSR. Again, the success rate I have is not 100%, but it responds some cases. Most recently, quite interesting, and I have seen several cases reported now for treating of CSR from steroid, and it's quite interesting. I don't know yet experience, but several colleagues has reported the use of periocular steroid, not systemic steroid, periocular steroid for the treatment of CSR from systemic steroid. So in other words, these are patients who've been treated with prednisone and for whatever reason develop CSR, and then the authors remove the systemic, and then as a form treatment, they report a series of cases where they treated with periocular steroid. And the rationale is being explained, but somehow that's improved with that aspect. But again, that's quite peculiar. So that's a little bit newer that we've just been seeing now in the literature a little bit. But going back to the using of CAI, Igor or Hassan, do you use that at all systemically in your patient?
No, actually, I'm not. I didn't have an experience to use Diamox or correlates in this patient who was having CSR induced by steroids. I have an experience with one of my patients who was diagnosed as a case of FKH and being treated aggressively with systemic steroid. And when I looked for the picture, it wasn't go with the FKH. So then I realized that this patient is really CSR rather than to be. So what I did, just only I stopped, that gradually I decreased the systemic steroid. It was really large dose for a long time, so I couldn't just stop it. But I'm assuming when a patient having CSR, you might use them, a lot of medication that like, spironolactone, treatment, it might help. This treatment usually is not an easy, and you need to do a lot of medical work for these patients. And the risk of, as you say, that hypokalemia, and even though the patient tolerance to the Diamox is not usually as expected that good.
Yeah.
Yeah, I haven't used it systemically. I've used it topically in 2 patients who had both uveitis and glaucoma. And in one case, I would say it has improved and stabilized the vision. In the other, it was not effective at all. Just topical carbonic anhydrase inhibitors.
The systemic dose is work quite well, and you can start with 500 q day and then 500 milligram once a day, and if they can tolerate, move up to 500 milligram twice daily. But again, we need to warn the patient some of the side effects, the tingling of the finger, and we need to explain that this is clearly not a long-term treatment. It's enough for us to get the fluid to get away, and then we get them off of that. But that's another tool that we can have before we can go on to other things. And certainly we can go back now to discuss other aspects there.
Okay. There is a Dr. Fawaz Al-Ma'mouri. He raised a question. What is your experience, panelists, in treating CME or uveitic macular edema secondary CME secondary to retinitis pigmentosa, which is also considered as a part of inflammatory macular edema?
Well, if I may start, we actually published a paper on it with Ahmad Mansour using Ozurdex implant and repeated in some cases in macular edema associated with RP, and it has shown efficacy in close to 70% of cases. So it's a good option. Again, bearing in mind, all the precautions we need to think of when using this therapy, but it's therapy that works.
The other situation is that, Nora, some of the initial work of the use of topical CAI was published on this particular thing here. So the use of topical carbonic anhydrase inhibitor has been shown to help with macular edema secondary to retinitis pigmentosa. Some other study have looked at intravitreal methotrexate, for example, but I don't think that was very reproducible data. So that didn't help. But if you go back, some of the initial work coming out from Illinois Eye Infirmary has been using topical CAI for this particular indication that you mentioned.
That's Gary Fishman's work, yeah?
That's correct. Yes, that's correct.
Yeah, it's great to hear about this. I'm using that's just only topical, medication in these cases, and like Trosops. But looking for the steroids could be good options. But unfortunately, this patient, they are at risk. They have, they're prone to have glaucoma, and they have usually their visual acuity is not that obvious, as you know, so that anything that could go in that way, it might. So the balance, I think we need some sort of clinical trials to compare this medication in certain, small groups, so it could promote using the intravitreal steroid in this patient, especially because this is recurrency and as well the refractory type of macular edema, and the inflammation is not 100% being sure it is the behind the retinitis pigmentosa macular edema. So we need to be cautious when we are starting to use that, rather just only. I will use it only for the patient really in a form of trials.
Okay. There's a question to Prof. Kwan from Dr. Al-Bakr. How frequent you use the implant in case of Behçet's disease? Because it's usually associated with systemic complaint and severe uveitis. Sometimes might reflect CNS activity. Need to know your experience of using implants with Behçet's, and does it mean to stop immunomodulators, for instance, 1 to 2 years?
Yeah, that's an excellent question there. So many colleagues in your part of the world are actually expert in Behçet disease. And so, but here's a thing that all of us can consider. So Behçet disease is clearly known to be a systemic disease with multi-organ involvement, the kidney, the brain, and the eye, among others. So when we use this, we have to think of treating Behçet disease as treating of a systemic disease. And oftentimes, in various countries, and so the use of TNF inhibitor has been considered nowadays the first line of therapy for the treatment of active Behçet disease, in particular the use of infliximab for that aspect, and very successful. So let's say that you are able to control the systemic disease, decrease the incidence of oral ulcers, and control there's no renal involvement or so. And let's say initially you have bilateral disease in the eye, and now one of the eye is quiet, but the other eye still have optic nerve inflammation or retinal vasculitis that's not well controlled. So at that moment, you have a patient with Behçet that already well controlled systemically with systemic therapy. Now you only have the eye that's active. So rather than subjecting that subject, that patient, to a much higher dose of systemic therapy and potentially with side effect, because it's now a local situation, you can then consider the insert of the steroid insert in the eye at that point, because there now you are well controlled with the eye that you're treating. You know that the rest of the body is very stable. It's just one right or left eye or even both that have the problem. Then you can put in the implant. So the goal there would be make sure that, as you already alluded to, this is a systemic disease, and the systemic disease need to be under control first and foremost, so that you can save the patient life. And then if need to, then we use local therapy like this, as Dr. Igor and Dr. Hassan mentioned, to treat the eye. And at that time, you can consider the insert of the steroid insert.
Yeah, I entirely agree with you on this route of treatment. Behçet disease, systemic disease, the most important to treat it systemically. And we have a lot of reports that been published regarding to the best treatment for Behçet disease that can deal with the intraocular inflammation and the development of macro edema and suppress the systemic. And among the medalists, we have that the infliximab showed really an excellent options for treat both. And looking for Turkish and Germany, they found that the interferon beta is really a great, choices to treat both. So it is really there is, and this has been supported by clinical trial, just not only by, retrospective studies. So the option is here to treat. If it is just only unilateral and the inflammation is really under control, then you can use the choice of intravitreal steroid by putting the implant. There are two types of uveitic macroedema in this patient. One of the persistent inflammation, low grade, or the secondary to an occlusive vasculitis that affecting the macula. So you have to differentiate between both of them so that you can use your best option to treat these patients.
Okay. Dr. Hassan, regarding, since you spoke about the classification, Dr. Altaf Arswala, she said, why do we classify the type of edema in uveitis? Will it change the line of treatment or approach, or does this help in prognosis for the patient?
Yeah, this can predict prognosis of the patient. When you have, the central macro thickness is that big, being more than 500, eventually that affect the prognosis. Acute versus chronic, old versus young. The second thing's combined type of uveitic macroedema, the treatment and the possibility of refract, that resistant to treatment is there, so you put it in your mind. If I tell you that if you have big cystoid changes, and that could predict that the that the elasticity and the stiffness of the macula is really effectively affected by the future treatment, and how much you go that you might need couple of or combined type of treatment to steroid plus anti-VEGF. So these things were actually, it's not limited, but could predict the future prognosis of the uveitic macroedema. It's important to put that in your mind so that you'd be clear, transparent with your patient, and select your plan of treatment. Certain patient might be one-eyed patient, might be patient for a long time being neglecting himself, not being treated. So you have to know this before you start your plan for treatment. There is nothing is magic to treat, and as still, if your all opens, it might be ended that you cannot able to manage this uveitic macroedema And as you said, that show the percentage is that most of the cause for impairment of vision is uveitic macular edema in general.
Okay.
Hassan, excuse me, do you think there is a component of neurodegeneration in uveitic macular edema, similar to diabetic edema, which also is inflammatory disease?
I believe in the chronic type, combined type for a long time, not being treated or touched, it might be affecting the integrity of the RBE and the neurosensory retina and lead. And we saw that in certain patients that they have very thin outer segment of the and inner segment of photoreceptor. So put that in your mind when you are evaluating your OCT. You have to look for these things there. And if there is escape or loss of that, if it's acute, it might be regenerated. But if it is for a long time, it might be the visual loss is permanent because of this.
Yeah, well, we know that structure changes with chronicity of edema, but what about neurodegeneration component as such? Do you believe it or not?
I believe in that, but not on all in the acute cases it could be, but chronic cases most likely maybe the damage is permanent. I don't know about Kwan.
So interestingly enough, this question of neuroprotection thing has come up, and within the past 6 months, there's been a publication come out from a group called the User Study, which among the colleague in the US who look at patient who has been treated with the fluocinolone acetonide insert. And we know the insert, the Iluvien, has been approved in the US and worldwide for both the uveitis, but the second indication for it, actually the first indication for it would be diabetic macular edema. So they've been using that, and in this user study, people were looking at, in addition to obviously the decrease in retinal thickness and thing, what happened to the ganglion cell at the optic nerve. And impressively enough, that the patient over a period of year definitely showed there has been a much less decrease in the rate of a typical ganglion cell loss in that aspect. So the question of, is steroid delivered in a concentrated situation like this can be so-called quote-unquote neuroprotected, it's not seem to be presented. Although we have to admit that this thing, neuroprotection, is being a mystery to many of us, and I think of now we don't have a very clear understanding of it yet. But at least based on this study, so the user study, it showed to be that there may have been some potential benefit with this aspect. So I would not be surprised if Dr. Igor and Dr. Hassan has mentioned that there is potential benefit over on this aspect as well.
I remember one of my patients, it's young, it was 14-year-old, and it's a case of PKH. And we're starting to treat this patient. He's been neglected, not diagnosed in the right times. And when he come to us, we're starting our medication. We looked for his OCT and looking for, photoreceptors, and we found really very badly affected. And the vision was around 2300. With the continuity of treatment, after 6 months, I found this photoreceptor getting back and the vision recovered. So it's really, this is support that the neuro regeneration is there. But is it applied for all the cases of uveitic macular edema, or that inflammatory cases, or for these people who's for chronic very stiff macular edema, and it being for a long time in old patient? It could be do the same, or early treatment could help in that in young patients and acute uveitic macular edema.
Okay, so there are a couple of doctors who are waiting to open their mics for questions. There are also written questions, so hopefully we can do it on time, but we'll give the chance for the 4 attendees who are going to ask you, gentlemen. First of all, we'll open the mic for Dr. Noura Al-Sibai. She's the first one who raised her hand in the beginning of the webinar.
Can we see Dr. Noura on the gram too, so we see who's asking us this question?
Dr. Noura, can you, Marbajan, if you open the mic? for Dr. Noura. Kindly unmute yourself. She's around, Marvijan. Can we go to the next attendee? Dr. Ibrahim Al-Anizi.
His mic is open now, so he should be able to speak.
We have Dr. Noura Sibai, Dr. Ibrahim Al-Anizi, Dr. Arkan Al-Ma'mouri, and Dr. Carter Chapara. So any of the attendees are welcome to ask in the platform.
Yeah, Kartar Chabra, can I go ahead?
Sure. Please ask your question.
He's muted now. He's muted.
Unmuted. Yeah.
Okay.
It gets muted. Yeah, my question is okay. Thank you very much for a very good seminar.
Thank you, Doctor. If you can just go into the question directly, so we can have the chance for the others. Dr. Carter?
Eels disease. Hello.
Yes, can you repeat your question, doctor?
Any experience of patient with Eels disease having macular edema?
So ill disease, by definition, is a diagnosis of exclusion of that aspect. Once we have already ruled out other possibility, what we, or at least I have seen in ill disease, are usually situation with retinal neovascularization that lead to, for example, vitreous hemorrhage and so on. So that has been the key thing for me, seeing an ill disease. I typically treat these cases in a way similar to diabetic retinopathy in the past, that is to perform laser photocoagulation in this type of patient in there. I don't believe that I have had many patients with ill, which are relatively rare anyway, to have macular edema. So I would think that if you were to see macular edema in the case that you definitely believe that it truly should be ill, and based on the concept of neovascularization that form in ill disease, I would think that using that concept now, thinking maybe we can consider a VEGF antagonist for that aspect, because in ill disease, the situation there happened with again increase in increase in hypoxia, and therefore increase in the VEGF formation. And with the past that they have responded nicely to laser, and now cases with anti-VEGF, I would think that that probably where you can consider it.
Thank you. Thank you very much. God bless.
Oh, thank you.
Thank you.
Thank you. Thank you, Dr. Kwan. Now the next is Dr. Noura Al-Sibai. Can you unmute yourself, please? Dr. Noura?
She's mute now. She's muted.
Okay.
Where she's now? So Ibrahim Al-Anizi is there.
Dr. Ibrahim Al-Anizi? Okay. Tell anyone. Can we have a question from the audience? Dr. Avinash, he raised a question saying that, let me have a look. Yes. In patients with unilateral intermediate uveitis with uveitic macular edema, if there is a strong steroid IOP response, what would be the choice of treatment?
So this patient has unilateral intermediate uveitis with macular edema. And can we, okay, so and now with active macular edema, and the patient already been treated, I guess, consider with both topical and also systemic steroid, and the patient has shown problem with steroid side effect and ocular hypertension. So not really a possible choice here. So then we can consider this patient and see, okay, so intermediate uveitis, typically in a young female group. So make sure that we talk about family planning when we choose about this issue here. Let's say that's been stable with, then I would again consider a step ladder approach in this case. I would most likely start a patient out in this case with a systemic CAI to see if I control it quickly. If not, I would then move forward to looking at some of the other biologics that potentially can be used in this patient. And we have had some very good success with IL-6 inhibitor, the tocilizumab, in this type of cases. So I would consider that. But just like other cases in uveitis, we go in a step ladder approach. So we consider things that are much more, perhaps a little bit easier for the patient to get first and then see how it responds. But if you already failed steroid, or in this case cannot tolerate steroid, then the next one will probably consider a systemic CAI, and then moving forward using a anti IL-6 in this case will be in this aspect. Why anti-IL-6 versus an anti-TNF? Well, if we look back at some distinct situation in the visual study, which led to the approval of adalimumab, which is a TNF inhibitor in there, the response to macular edema can occur, but it takes quite a bit of time for it to get response. So we did see some response into a macular edema, but it takes very long time for us to be able to see that. So therefore, the IL-6 tend to be a little bit faster to do this aspect from there. And so that's the reason why I prefer that over the TNF inhibitor. And if you cannot find IL-6 and you want to use a TNF inhibitor, in this case, then in this particular end, I would go ahead and choose the infliximab over the adalimumab first, because the way that infliximab delivered through the intravenous, it can lead you to improvement a lot faster than the adalimumab part. And again, this is in the setting of a patient who cannot be treated with steroid. So certainly with the other aspect as well, we have to consider that, and just please make sure discuss family planning and think if appropriate, so that way the patient know what to need he or she need to do.
I entirely agree with you, but we have to be careful when are diagnosing bilateral intermediate uveitis. So we have to make sure that we don't have an infectious cause of low-grade inflammations. Otherwise, what Prof. Kwan mentioned is the step ladder approach is the best.
Okay. I think we are running out of time, despite of there are interesting questions and people eager to have answer from you, gentlemen. There is a mic, if you can unmute yourself, Dr. Arkan Ma'mouri. For the meanwhile time, I'm going to send a link. I'll share it with you, attendees, so you can receive your certificate once you write down your email, and it will come to you directly in your email. Dr. Arkan?
Muted. He's muted.
Okay.
Dr. Noura, do we have any questions that have been sent to us by
There are a lot of questions.
Oh, we could not see any of them. That's why I could not see anything. Sorry.
Okay, let us, there is from Dr. Noor Uthman. She said that my question is that how can we approach to a patient who needs cataract surgery with previous history of uveitic macular edema? Are there specific pre-op protective measures? It's a nice question regarding preparation of cataract surgery and history of uveitic macular edema.
It's a great, and I think one of the options to use intravitrial implants, either Ozridix or Olivine, is one of the really good options for these patients.
Okay.
So if you have a good response with that in the past, then definitely, Dr. Hassan said, you can consider that to place. Otherwise, if you have never treated before, the patient only have a history of recurrences, then you can treat the patient, pre-op the patient. I usually use it about a
As
week
usual.
before. Yeah, so the 7 days before, where you would consider a short course of systemic steroid in addition to topical steroid, just about 7 days of that. And then on the day of surgery, we will administer intravenous steroid. And then in the post-op course, depending how the inflammation is, then you can adjust. Again, this is based on Dr. Noura scenario of a patient with a history of recurrent macular edema from uveitis. So this is a high-risk patient. If the patient never have had any problem with uveic macular edema, and the uveitis has been relatively quiet or easier to control in the past, then I think a topical course of heavy steroid, topical steroid and non-steroidal a week before is fine. But if they have had a history of recurrences, then definitely please consider systemic, because that decreases the risk of that. This patient had very high risk of recurrences after the cataract surgery.
Okay. Talking with the implants, in real life, the effect of Iluvien lasts up to 36 months. If not, on average, how long Iluvien lasts in the eye?
I thought to be very closely attentive to like around 20, 2 years to 2.5 years, so 24 to 30 months of this aspect of there. Again, and based on what we have seen with the registered previously, it's very, even though say 36 months, but sometimes you see the activity lasts beyond that, and you see more than that. However, with this caveat, I also want to point it out that yeah, it is said to be 36 or 31, but one need to be careful with the activity, because what we have learned from the so-called the MUST study, the multi-center uveitis treatment trial, MUST, in that where we compare systemic therapy to Radicert, what they have learned at the 7 years is that the patient who were treated with the Radicert tend to have more diseases. But the problem is the average number of implants that was placed in that trial, it was less than 2. So while those who will receive systemic therapy receive continuously all systemic treatment throughout the 7 years, those who were randomized to the Radicert will only receive less than 2. And the claim is that because the investigator did not see activities in the eye that have the implant, so they did not treat, and therefore they wait for problem to occur, for example, subretinal fibrosis or choroidal neovascularization or whatnot. So my thinking is that, again, we have the implant in the eye and it's slowly controlled, but it would take a little bit of time to show you recurrences. So at around the 24 or to 36 months, you should be quite actively looking for potential disease, because we may not see all of them at once. So look for fluorescein, look at OCT, look at multimodality to detect whether there's any evidence of recurrences. If so, then you should retreat them rather than wait until you see a real problem, and at that time it may not be reversible.
Okay. There are 2 last questions. Can you bear with me answering, and then we wrap up and before we finish, from our dear attendees. Dr. Mahmoud Abul Atta, he said 36 years old male patient. You know, we have great speakers, so we need your input for the patient. 36 years old male patient presented with diminution of vision in the left eye, 660. Eye is completely quiet after severe attack of uveitis at childhood. OCT showed only extrafoveal thickening. Macular thickness was 265. His right eye is non-seeing, so he is single eye. What is the next step for the left eye? Is it like observation or what do you think?
I would do fluorescein angiogram.
Mm-hmm.
to see the circulation and perhaps highlight that area, perimacular area of edema, and definitely assess foveal avascular zone and to look for macular ischemia. So before any treatment decision, I would like to have that test.
What's the vision, Dr. Noura?
660.
I'm sorry,
660.
660, and the thickness is 265, and a single eye.
And
The
there is
challenge-
no intraocular inflammations, is there?
White.
By examination, quiet eyes.
Yeah,
Quiet
this
eyes.
is what they has.
So the concern here is we're asking the question, why is it 2200? I believe this is the correct conversion, but like, why is it 660? What is it that caused this patient visual acuity to drop? So Dr. Igor already suggests FA to rule out ischemia. Other thing I would really consider is this, to perform electrophysiologic testing to see what the optic nerve functions like to VAP and look at multifocal and full field ERG for us to re-understand if there's a reason for this. So for example, if you do field and you do ERG and it's come back, ERG is nearly flat in the periphery, then you could say, okay, this may not be a regular typical uveitic disease because the patient is only 36, why is it all flat? Is then underlying genetic disease or some other diseases that have manifested like this? Because 2200 or 660 in an eye with no macular edema is a little bit unusual there. And so we need to evaluate why the vision is so low to the optic nerve, to the rest of the retina, that can give us a hint about what it is that we are seeing there.
Agree with you totally.
Yeah. And the last question, is there any role for vitrectomy for refractory macular edema without VMT?
So this question of vitrectomy for macular edema, and Igor Famrito, he's a great surgeon, so he was shared to start a lot out in Japan, where many of the colleagues in Japan in the past has used vitrectomy as, in some cases, treatment for diabetic macular edema to remove with or without traction at this aspect. I think in terms of uveitic with macular edema without any traction, so the question would be, why do we do vitrectomy? The goal there technically would be that you remove the vitreous, which is a storage device for a number of inflammatory cytokine and things in there that would do in that aspect. So potentially that can help. So rather than, let's just say the disease is very localized to the eye only, and rather than giving the patient systemic treatment or even like implants and or insert and whatnot, if you do the vitrectomy, it is hoped that one will remove that stimuli or stimulating factor to remove that to help. So if you're going to do that, at least for your own interest, you should definitely have those vitreous specimens studied carefully to see what you learn from there. And then you then ask the question, if you do that, what will prevent it from coming back? So then one have to say, why, if we do this vitrectomy, we remove it, is there anything to prevent the inflammation from coming back later on once, after that vitrectomy? So certainly that's considered, and recall that in the past, there's been publication from Boston, from Miami, showing the role of vitrectomy in intermediate uveitis with macular edema. So that has been shown, but the theory would be to remove that and with the hope that it would not return. So
yeah, but this is actually in the cases where there is persistent inflammation not responding and persistent vitritis, I think so. It's just not only applied for all the patients with intermediate uveitis, I think.
Yeah, definitely. And I would look for the source of inflammation. Is it coming from the blood vessels? Is it coming from pars plana? Is it coming from, choroid? And I would do that to do also a little bit of clearing of visual axis. So I wouldn't do it initially. I would perhaps wait for more cloudy vitreous to, so that the patient can see a benefit. you know, and that's an option. You know, we have cases that really end up with lots of vitreous debris following vitritis, and vitrectomy in such cases is also therapeutic, but also a very good point from Dr. Nguyen to use it as diagnostic vitrectomy and try to look for some either cytokines or maybe some infectious causes.
Well, I'm not using vitrectomy unless there is the reasons in that. If the media is clear and there is no vitreomacular reactions, actually, I'm not. This is like in my amentoriums for the treatment of uveitic macular edema. But if there is really and media opacities or recurrence vitritis that prevent me to evaluate very well the posterior pole, this is the time where I have to go. I found it very useful in a young patient with intermediate uveitis that having recurrent, inflammations with vitreous debris and a lot of floaters. But for sake of treating macular edema, actually it is not the first choice for me.
So, yeah, Dr. Prof. Kwan, do you want to say anything regarding?
No, I think that our colleague students share very beautiful information already. The only other option that since we turn the topic of uveitic macular edema, I just want to share with everyone, and Dr. Igor and Dr. Hassan and probably you, Dr. Noura, already seen some of this data presented. So in the US right now, the study, so-called the Peachtree study, looking at suprachoroidal steroid. And that study was specifically designed for uveitic macular edema. So this is not to the insert implant, but rather to the suprachoroidal delivery of steroid. And that is being evaluated right now. The study was positive for that, so that may be a potential too. And I'm quite certain that eventually it will probably move to the rest of the world as well. But that is another approach. And that particular study is indeed for that uveitic macular edema that we're looking for. But so overall today, certainly it's been a wonderful experience learning from our colleague there and seeing friends. We have been logged in for so long now, so it's very nice to see humans and faces and smile again and things. So thank you, Dr. Noura and Dr. Igor and Dr. Hassan for having us.
Thank you so much, Professor Kwan, Dr. Hassan Adibi, and Dr. Igor Kozak. Hoping Dr. Kwan and Dr. Adibi to welcome you in United Arab Emirates and meeting you face to face in person, inshallah. Thank you so much for your great talks. Thank you, attendees. Thank you, Alimera, Shadin, and Balqis for your great effort. Thank you, Marvijan and Dina, for your conducting this webinar through live channels in Facebook and YouTube. The link I have submitted, I shared the link in the chat box. You can print your certificate once it's in your inbox. Till then, stay safe and looking forward for a healthy environment to meet in person. Good night.
Thank you very much.
Thank you. Bye-bye.
Have a nice day.
Bye-bye.
Thank you. Bye.